Perfect. So I'm going to talk about use of ultrasound in cardiac arrest. We'll talk about what sort of how it can support decision making during cardiac arrest and how incorporated into a team-based approach to resuscitation. And how do you actually train people in doing that and highlight the role of simulation? And I'll start with a case which sort of illustrates why it may be useful. So this is a 49-year-old woman initially presented a few days ago with traumatic subarachnoid hemorrhage. She recovered well without neurologic deficits. However, she developed sudden hypotension. This was like day 3, day 4 after the initial, day 3 after the initial event. Sudden hypotension, and the rapid response team was activated to assess what's going on with the patient. And unfortunately, by the time rapid response team got to her, she was receiving CPR. And here you actually see ultrasound done during the CPR. So for those of you who may or may not know what we're looking at here, we're actually looking at subcostal view. So the heart is positioned horizontally. The chambers on top are the right-sided chambers. So ventricle is here, atrium is here, and the left-sided chambers are at the bottom. And what we can see that a heart sort of comes in and out because of the chest compressions that are being performed. And even now I can see that the right-sided chambers are dilated. So it's much easier to see what's going on during the pause between chest compressions when we do pulse and rhythm check. So it's the same view that we already saw, but now is done during the pause. And again, right-sided chamber, heart moves, right? So that's not a true PEA. We would call it pseudo PEA or false PEA, because even though there is no blood pressure, for example, no pulse, the heart is moving. So, and we'll talk about the meaning of that in a little bit. So we did that. So we see the heart is moving. Now we have decided what is the cause of the arrest. And in this patient, we presumed it was acute pulmonary embolism until proven otherwise. So this patient received tissue plasminogen activator, and resuscitation was continued. About 20 minutes later, we see that the right-sided chambers look better. The left side, you can see, is still not much blood flow in there, but it's better than on the previous slides. And then eventually patient gets return of spontaneous circulation. So now we can complete the full evaluation of the patient. And again, you can see that starting with subcostal view, again, right-sided chamber looks like it's moving better. And the tricuspid valve here, which is a measure of the right ventricular activity, actually moves better horizontally here. This is the parasternal on axis view, reflects the same thing. Left-sided chamber, we see more sort of blood being delivered to the left side. Right side moves better. This is descending aorta. This is left atrium. That's aortic valve here, mitral valve here. So the blood flows on the left side. On the parasternal shore axis view, we see the heart, again, left-sided is filled up better, even though the septum is flat, which is, again, reflection of high pressures on the right side. And this is a 4-chamber view, apical 4-chamber view. Again, more blood being delivered. So patient had ROSC, return of spontaneous circulation. So that's one of the way of using ultrasound during the resuscitation and for early assessment. So that's just an illustration. So here we'll focus on in-hospital cardiac arrest, because again, being an intensivist and attending to patients during cardiac arrest, that's what I usually do. In the United States, it's roughly 200,000 per year documented. although the most recent data extraction I looked at, this is American Heart Association get with the guidelines resuscitation investigators. It's a nationwide database. They claim it's up to 290,000 arrests actually been documented into that database. About 60% of those happen in the intensive care unit where resources are more concentrated. Out of in-hospital cardiac arrests, ventricular fibrillation or pulseless ventricular tachycardia happen in 20 roughly percent, and in 80% or 4/5 of those arrests are asystole of PEA. Overall, return of spontaneous circulation is 47%, but it's largely driven by the arrhythmias, right? And those have much better outcomes. Even though we get ROSC in 47 or half of those, survival to discharge is only 18%. And out of those who survive to discharge, about 3/4. So there is variability in terms of who makes it, right? If you're in the top performing hospital, more people will survive to discharge and have better neurologic outcomes. If you're at the bottom, fewer patients will do that. So why it matters, right? Because hospitals have better outcomes because of the entire system of care as opposed to outpatients. Hospitals can get prepared by having equipment cohorted together, like automatic defibrillators and code cards, emergency response teams who have expertise in managing cardiac arrest. All those providers can receive ACLS training, advanced cardiac life support. And many patients actually receive monitoring, particularly if you talk about ICU patients. So that's pre-arrest. So the building the system that responds and surveils for the development is important. And peri-arrest CPR is the mainstay in therapy, as well as early defibrillation. Avoiding hyperventilation and identifying reversible causes are important. And post-arrest, actually standardizing care pathways and taking care of those patients are important, and protocols for hemodynamic optimization. So what I did, I highlighted with a star actually where ultrasound can be useful, and it definitely can help around the time of the arrest itself as well as the post-arrest. Remember, mentioned that better outcomes usually driven by the ventricular fibrillation and ventricular tachycardia. If timely defibrillation is provided, there is much better survival to discharge, right? And because of that, both return of spontaneous circulation and survival to discharge is better. However, systole and PEA over years, they still relatively low. And unfortunately, most of the in-hospital cardiac arrests are PEA arrests, so it drives down or actually decreases the chances of survival and good neurologic outcomes. This is a very quick note on time of defibrillation, right? So the faster we do that, the better their outcome and survival to discharge, such that if it's less than 2 minutes, it's about 40%. And if it's more than 2 minutes after the initial sort of arrest and the first defibrillation, it's like half of that. So anyone who has arrhythmia as part of their presenting should receive defibrillation immediately. That's a very quick note. And this is actually one of the things when we don't use ultrasound, because that will delay defibrillation. So that's one of the things we teach residents, fellows, faculty. When you see that, just defibrillate, don't delay. Everything else will cause a problem. Now, shifting to the PEA or pulseless electrical activity arrest, there are two main questions. Is there really a pulse, right? It's always a problem. And what are the reversible causes in this patient? So let's see, I mean, about a quick note about the pulse.
Yeah, there's a pulse. I don't have a pulse. That's a pulse, right? I don't know. It's your pulse. Totally different pulse, man. Okay, no, what are you talking about? This is a pulse. I'm writing you up for this. I'm writing you up for this. There's no pulse. We're not. I don't need to do compressions if there's a pulse, guys.
So then you can see it's a staged performance to show one important principle that sometimes identifying pulse can take a while, right? I mean, this is a simulated case, but in reality, when people make assessment for pulse, it may take up to 30 seconds to reliably detect a pulse. And many studies were actually done in the cardiac operating rooms when they asked people to actually detect pulse when there was a clear cardiac activity and blinded to the readings on the to both ultrasound, transesophageal echo, and arterial line tracings. And it does take over 20 seconds to determine that. So because of that, I mean, ultrasound can actually help tremendously. Those are the kind of scenarios we can see. That in true PEA asystole, you will see no electrical activity if it's asystole, or true PEA, you will see electric activity on EKG, but you will see no cardiac motion. That's what we can see in reality. We can also see what is pseudo PEA, which I mentioned. There is electrical activity, but there is also cardiac motion on ultrasound, right? So it may not be generating enough pressure to feel a pulse, or maybe generating enough pressure, but pulse is just not felt because of limitation of our palpation and feeling for that. And a final situation where ultrasound can be profoundly helpful is in a pseudo asystole, when on EKG we see just what we appear to be asystole. It can be in reality very fine AFib, and you can see the heart is really just fibrillating very finely. So defibrillating sometimes in people who appear in asystole, and if you don't have ultrasound, you see that, is not necessarily a wrong idea, because you can see that the heart is moving, and here you on this particular slide you see that it's it disorganized motion. So pseudo PEA is actually common, and it does entail good prognosis. And in this particular meta-analysis, there is like patients were studied, and outcomes for true PEA when there is no cardiac motion, and pseudo PEA. And half of those patients present pseudo PEA, and they definitely had better ROSC. So even defining prognosis is really important. So if you see that, I mean, your efforts to try and resuscitate patient can be more concentrated. These are classic 5 H's and 5 T's of PEA arrest. And I highlighted those, I boldened those that can be seen by ultrasound. Dr. Milaku, you're not on mute. If you can mute, that would be great. You can see that like hypovolemia, tension pneumothorax, tamponade, pulmonary thrombosis, or like pulmonary embolism, thrombosis cardiac, or acute MI. You can visualize those. So good half of the causes can be visualized using ultrasound, and then just focusing on the rest, like hypoxia, acidosis, hyperkalemia, hypothermia, and toxins, which you can rule out based on patient history, can be rapidly identified. So it can be extremely useful in identifying 5 causes. They're just using that statement among the blind, the one-eyed man as a kin, right? Ultrasound provides you with that eye, so you can actually see what happens. So how can it be used? Is to evaluate for treatable causes of cardiac arrest, help establish prognosis. As we mentioned, if it's a pseudo-PEA, it's a better prognosis. The latest recommendation, if you see it's a cardiac standstill, you cannot just say, hey, we cannot do anything. You just have to realize that the prognosis may be worse than otherwise, but you should not make decisions about chest compressions just purely based on the standstill. You can also detect subclinical return of spontaneous circulation. Right? Again, remember we talked about limitations of palpating a pulse. And evaluate effectiveness of compressions. That's the whole new way of doing it. It's much better to do through transesophageal. So some places that have started doing that, they can monitor the quality of CPR. However, there is also some literature emerging that you can repurpose your probe, the transthoracic probe, and look at patient that way and ensure quality of CPR. What views? We briefly mentioned it during the case, right? Subcostal, we almost invariably start with the subcostal because it's away from where chest compressions are done, right? It's in the space right below the sternum. Parasternal long axis, also documented in the literature as being rather good. Then short axis, and finally apical. Apical seems the most difficult to acquire, so we usually put it aside, but those are the options. So you start from subcostal if you cannot obtain, and you have other options. So that's how things look like, right? So I mean, this is hypovolemia. And this is interesting because this is actually parasternal short axis. And the reason you don't see much, you can see that something is moving, but you don't see black as part of your image because there is literally no blood. So the heart is trying to work really fast and squeeze everything that it has, but there is nothing to push around, right? So that's how severe hypovolemia. And on this side, you see same heart, but it's the subcostal IVC view. So where I'm trying to point with my pointer here is the IVC, inferior vena cava. And it's like you barely see it sometimes, right? So this is a person who has like literally no volume on board. This starts looking familiar, right? This is the acute right ventricular failure, which can be in setting of pulmonary embolism. It can also happen that someone has history of pulmonary hypertension and they just go into pulmonary hypertensive crisis when they just cannot deliver to the left side and the patient just crashes. This is tamponade, right? Looking through the liver, again, subcostal view, you see tons of fluid around the heart. You may not necessarily see the chamber collapse because we don't see a good right atrium. However, if someone is arresting and that's what you see, that's tamponade until proven otherwise. So prompt pericardiocentesis is required. Finally, this is a person with acute left ventricular failure or myocardial infarction, right? I mean, you can see this patient already has like a pacemaker or AICD leads in place. And the right side seems to be moving, but there is like no motion on the left side. So that's if an acute decompensation, and if you know that a person had a decent heart function, that this is acute MI until proven otherwise. American Heart Association, in their adult basic and advanced life support, they make a statement about ultrasound. If an experienced sonographer, so someone has to be trained, is present, and the use of ultrasound does not interfere with standard cardiac arrest protocol, that's what we mentioned. You also not only need to have a person who knows how to use the ultrasound, you also need to make sure that all the resuscitative efforts are performed. And we'll talk a lot about it for the rest of the talk. Then it may be considered as an adjunct, although its usefulness has not been well established, right? So you have to use it by the right person and in the right way, and you may still get supporting information, but we really needed to investigate more. And as more and more people start using it, we will get more information and we will understand, does it help? Does it hurt? There is some literature that it may actually hurt. And by extending the pauses that people do for pulse and rhythm checks. So when can it be used, right? So all of us know that we perform continuous CPR for 2 minutes. If it's ventricular fibrillation or tachycardia, we just shock. We don't waste our time for anything else. However, if it's a PEA arrest, we do 2 full minutes. And when we do rhythm and a pulse check, that's the time we can do ultrasound. So rhythm pulse check becomes rhythm pulse ultrasound check. And that's what we do. And we define what we see. Let's see how it looks, right? It can also become a great distractor. And that's what I mentioned, that we can extend the pauses tremendously. So like this group perform CPR for 2 minutes, and now all of a sudden they do ultrasound and see what happens.
Yeah. There's a heart. Good.
Yeah, so you see all of a sudden, instead of actually paying attention to the patient, like the whole team starts looking, oh, I've got an echo, right? I mean, I'm gonna start looking at the screen. I see the heart. Oh, let's talk about it, right? I mean, and they're forgetting that the main thing they have to be doing is actually chest compression. So there is potential for harm by prolonging no-flow intervals because it can be very distracting, and that's why those skills have to be trained, right? So these are the several studies that were done on this subject. If you look for pulse check, right, and you with or without ultrasound, and you see what those durations of pauses, right? You see some studies that say it's substantially longer when ultrasound is used. It's in the columns that say yes. And there are studies that say no, it doesn't really prolong, right? So when you actually read those studies carefully, in the ones that say no, it doesn't prolong the pauses, all trainees underwent specific training before they started using ultrasound for cardiac arrest. And the training is what made a difference. It's not the use of ultrasound per se, it's actually how you use it and what you do about it. So difference really is due to teamwork. So the teams are learning together. So and I'm going to show you on an example, right? And since we always talk about CPR and resuscitation as choreography, so I'm using examples from ballet, right? I mean, which requires extensive choreography. So the first one is like when everyone sort of does what they do. So let's see what happens. So pay attention to this particular one. So you see everyone sort of tries to do one thing, but one is like doing their own thing and totally distracting others. So see what happens when people work together, right? Completely different experience, right? And since we call it choreography, is how people work together. I mean, those are good examples to show them. So to make it happen, right? To make it happen, right, you need a protocolized approach. And we also clearly teach people that ultrasound really does not replace ACLS. It really augments it. It's executed in tandem with CPR cycles. And the training is there to minimize duration of no-flow intervals. There are many protocols, right? I mean, I just put like alphabet soups here. There is CAS, CASIS, SESAME, FEAR, I'm not actually going to even go over all of them. What we really need to do is like whatever we train our providers, they should just be using those consistently over and over and over, because consistency is what makes a difference and training is what makes it different. Few of them really tested in clinical practice, meaning the effect on outcomes. And that's why like American Heart Association is not making a recommendation which one to choose. So general principles where ultrasound is always prepared in parallel to CPR. That ultrasound is obtained within 5 to 10 seconds during the rhythmal pulse checks. And again, it becomes rhythm pulse ultrasound check. Images evaluated while continuing CPR. You don't make assessment while resuscitation is ongoing. And you close the information loop. So the person who does ultrasound is a dedicated person, and they communicate to the team leader what their findings, and the team leader is able to make decisions. So training, we usually train it in the context of ultrasound course, because some of the people are novices. They don't necessarily know how to use ultrasound. So we teach both. We teach what the protocol to use and how we incorporate it into the CPR. It's an emphasis on high quality CPR. We work really hard on building teamwork and leadership. So it's very similar to the training one receives for like during ACLS training. So you can think of it as ACLS protocol plus ultrasound. So there are several stages, right? So that have to happen. Team leader definitely leads the effort, and they assign roles for the pause. So it's like you give drugs to the patient. You're responsible for the airway, right? Another one is responsible for ultrasound. So you're identifying for the ultrasound, and also start preparing for the pause. Sonographer actually has to report back so have this closed loop communication. We'll tell the team leader, I'm here preparing the ultrasound. Great, thank you. We know you're there. And start preparing. What it means, the insurer screen is set, right? So it's a preset for deep scanning, like 20 to 22 centimeters or so. Gel is already on the probe. They position themselves such that they don't interfere with chest compressions, and they're getting ready to start. One other thing which is important for them is to hold a towel or some sort of material sheet to remove the gel as soon as they are done with ultrasound. Why that is important? Because if you decide to defibrillate or deliver electricity for cardioversion, you can actually create an arc, because gel is water soluble. So instead of defibrillating the person, you can actually create a burn on the skin if you don't wipe off the gel. So everyone is getting ready. So, and right before the pause is announced, right, the team leader can announce, or having someone who helps to manage the pause announces, oh, okay, hold CPR, start the rhythm pulse check. The ultrasound sonographer will be already on the chest with the probe, and as soon as the team leader announces that, they start obtaining images. And most importantly, hitting the save button to save those images so they can be reviewed. The team will perform ultrasound, that's a sonographer. They will check for pulse, they evaluate rhythm, and they will rotate CPR providers. I mean, remember, doing CPR is a hard work. Chest compressions is a physical job. So you want your team to be successful, you rotate them. Sonographer will place probe just prior to ending compressions, and they will start with subcostal view. If not successful during the same next cycle, they will go to peritoneal and so on. They will obtain image and then capture the clip. Capturing the clip is important so they can actually review it afterwards and sort of to make determination as to what they saw. Phase 3 is remove the compression. So phase 2 is when the pulse rhythm ultrasound check is performed. Either team leader or someone else on the team counts, right, and says 10, 9, 8, 7, 6, 5, 4, 3, 2, resume compressions, right? So the pause is no longer than 10 seconds. We really need to shorten that pause so that the CPR is uninterrupted. Team will resume CPR, sonographer will remove probe and will quickly wipe the job. I already mentioned, it's extremely important. And then as the team continuing the CPR, sonographer will communicate back to the team leader. And I'll show you like phrases that sonographer can use, and team leader will listen and incorporate the findings into what we're doing next, right? So if there is tamponade, says, hey, appoint someone responsible, you do the pericardiocentesis, right? Complete the loop. What we will look for is that heart moving, not moving, and if it's moving, what's happening, right? Is there a tamponade, left ventricle moving, right ventricle, there's signs of hypovolemia. So this is how what the sonographer can report. They can say, hey, this image is bad quality. I cannot give you any further information. Great, report is done, right? And say, great, good quality, heart is moving, and there is a large pericardial effusion. Team leader can make a determination, well, sounds like this patient has a tamponade, let's do pericardiocentesis. It's much worse if you start, well, it looks like the heart is moving. I don't really see the right ventricle well. Left ventricle seems like moving. That's not the good information. And I mean, in fact, it just confusing and distracting the team leader, right? The team leader really needs very focused information. Remember, we talked about choreography. So in our training, we usually put people into certain places, and every year in the sim center we teach teams. We started teaching ultrasound more and more, although not everyone who attends to codes actually is using ultrasound, and not everyone goes through that training, but our goal is to make it as routine as other CPR training. So usually what we do, right, we see the room entrance is on the right side of the screen. So what happens is that it's a pathway to bring equipment in and to move equipment out. And because that's a traffic area, we will position people who do chest compressions on the side opposite of that, right? So there will be a line of them, 2 or 3 of them waiting, right, when they switch during each cycle. Commonly, we would place the team leader would be at the foot of the bed, and the defibrillator tower is also at the foot of the bed, and with the ultrasound potentially being towards the chest. So again, minimizing the traffic and also allowing the area for someone who does drugs, right, have access to the patient and deliver drugs. Here you can see at the top of the bed, it's actually myself and doing airway. So I'm in charge of airway. So those things can be played, and can within each center can be choreography can be created. but is the more standardized choreography is, the better it is, right? I do want to show you a quick example. That's about a minute long video, but it shows how we play out incorporating ultrasound into the into resuscitation. So that's a patient who has an arrest, and you can see it.
Sir,
That's the first responder.
sir,
It's the code bell.
then can you get the private cash card? Yeah. In the back door, then
And everyone starts CPR, and then everyone else is optimizing the patient.
you manage to get away.
So the team leader is at the foot of the bed.
Backward, back side ready, on your count. Yep, roll towards Rika. 1, 2, 3, roll. Good, give me compression. With the front pad, we're gonna put it out in 3, 2, 1. Good compressions.
And you see it's placed in a way to free up the subcostal area for ultrasound.
I'm turning on the Zoll. Analyzing, stand clear.
And remember, defibrillation takes priority over everything else. So we try to determine if we need to defibrillate.
It looks like we're coming to the end of our 2-minute cycle, so better get ready to do information with the ultrasound. Rika will get field vision pulse check, and we'll also switch compressors at this time. Ultrasound is ready when you are. Compressions, 10, 9. This patient has no pulse, 7. We're still in PA arrest. 5, 4, 3, 2. We're doing compressions.
And you see providers were switched, right? So the CPR is performer.
It was a good quality image. The heart is moving, LV's dilated before contractility.
It looks like we might be in PA arrest due to acute LV failure. Rika, will you go ahead and draw 1 milligram of epinephrine and also get an inotrope ready? Get an epinephrine and also leave ready. And epinephrine and leave continue question.
So you see, remember we talked about choreography, and you can see the whole team is sort of working together. They almost know where each one goes and who does what function, and that allows for much smoother performance. And incorporating all the priorities. We do that in a simulated environment, and we actually do multiple cases at once, and I'll tell you why, show our data, why you need to do multiples of them to actually make sure people work well. And this is one of the scenarios we use. One here is like bedside nurse calls to evaluate for new onset of tachycardia. The room is set up for that. They just had carotid endarterectomy, had good neurologic exam, remained intubated just because of delayed emergence, and has a history of coronary artery disease, coronary stent, has essential hypertension. And all of a sudden, that's what happens on the monitor. That's what we see, right? I mean, patient is in normal sinus, and all of a sudden, it develops pulseless tachycardia on the subsequent screen. That's all you see. Blood pressure is like that. So initially there is pulse, right? Because blood pressure is that. But if you don't carry avert, that will progress and become pulseless tachycardia or ventricular fibrillation. And that's what happens eventually, right? So this defibrillated, unfortunately, after defibrillation goes into the PA arrest. So that's what again happens. And you can see on the screen, there is a PA arrest. Someone is doing chest compressions. And this is getting ready for the pause. The team leader says, hey, get ready for CPR. The probe is on the chest. You can see the Zoll pads. Patient is ventilated. checking for pulse, checking for ultrasound, resuming compressions after 10 seconds. That's what you see on the screen initially. So continue CPR because I mean it's a minimal movement, but the whole heart is not moving. Probably, given this situation, most likely had acute myocardial infarction, early postoperative infarction. More CPR, heart gets better, but unfortunately at the end, after like 20 minutes of CPR, that's what happens. So all you see here is blood actually almost like starting forming a clot. It's just like shimmering more so with the someone continuing respirations, right? So there is a little bit of movement of blood, but there is no contraction of chambers. So these are right-sided chambers here, right ventricle, blood just filled up with blood. Left ventricle, there is no motion, just shimmering of blood. Left atrium is here. So unfortunately, progressed to cardiac standstill. We had to declare that this patient died, but that's part of scenario to recognize what can actually happen. Why we do multiple runs of it? So when we looked at 12 teams performing in those capacity, each one performed in 5 ACLS scenarios. Remember I said in the context of training course, what we see in like every single scenario, we see improvement or shortening the duration of those no-flow intervals because everyone becomes aware. We need to go back on the chest. We need to continue CPR. We need to make sure that patient is doing well. And even after 5 of those scenarios, we still roughly 35% when we're compliant. But we're shortening, the average interval shortens to like 12 seconds or so. Not perfect, but it does take multiple repetitions to actually for people to perform well and really, really have to be aware how to manage those pauses. What we examined, right? I mean, so how many pauses are less than 10 seconds, 11 to 15 seconds in gray is up to 20 seconds, and then more than 20 seconds is in yellow, right? At the first scenario, you can see that almost half of patients, some of the pauses that between CPR cycles are in almost 50% greater than 20 seconds, because ultrasounds just can distract people so much. And after they do several simulations, in the 4th simulation, the absolute majority of them is, or like 65% is less than 15 seconds, and less than 20 seconds, or over 20 seconds is only 10%. Substantial improvement, not perfect. The funny part, if you see this small graph, remember some of the studies I mentioned that said, yes, ultrasound extends, no, ultrasound doesn't extend. This is from the study that actually showed that ultrasound does not extend, but it showed before and after training. And when you look at and after training results, they're almost identical to the ones that we showed. So it actually, between both of those studies, is like shows that training really matters. Training, and simulation, and possibly repeat simulation really matters. So where we are now, right, we try to refine training to drive times, how to actually make training even more effective. We do try to roll out this program hospital-wide, which includes training and actually consistent team leader and sonographer at every code in RT. That's we've been talking about it for many years, but I mean, now we start having real pathways to do that, and organize data collection to actually show that we're not harming the patient by prolonging no-flow intervals, because our own pads, the defibrillator pads, can collect that information, and we can see it on the back end. We did do this program actually in other institutions, like this type of training. So some institutions pick that up, and I do it routinely at several society. training, and we did it abroad actually. Last time we did session like that was in Egypt during the Egyptian Society of Anesthesiologists meeting. So that's it for me, and welcome any questions.
Okay, thank you, Doctor, for this very insightful presentation. So the next 15 to 20 minutes will be for comments, questions, and suggestions. So anyone who has questions or suggestions can raise.